Good morning and welcome to the Next Steps in the Sequence, a special event for all of us interested in the implementation of genomics for health in the UK. My name is Mark Cruiser and I'm Director of the PHG Foundation. To those joining us via live stream, we are limited for time, so we will not be taking questions, but do please join the conversation on Twitter or LinkedIn using the hashtag Genome UK, as we're keen to hear your thoughts too. For anyone not familiar with the PHG Foundation, we are a health policy think tank that seeks to make science work for health, especially in genomics and related technologies. We are a multidisciplinary organization and a charity of the University of Cambridge. We have been working in policy to support the use of genomics for population health and healthcare for nearly 25 years. It is in fact 10 years since we published our report called Next Steps in the Sequence that posed the question, what will rapid advances in genome sequencing technology mean for clinical and public health practice? It was therefore a watershed moment for us when the government's Genome UK report, published last September, set out the new National Genomic Healthcare Strategy. Along with the development of the National Genomic Medicine Service and the Genomic Test Directory in England, we believe that this was a pivotal step in the progression of genomics and health in this country, setting out as it did long-term and wide-ranging plans for making the most of genomics, not only in specialized clinical genetics, but also more widely across the NHS, and for both the prevention and management of disease where the evidence shows it is beneficial. I'm therefore delighted that Lord Bethell, the Minister for Innovation, is able to join us today. As many of you will be aware, Lord Bethell's portfolio at the Department for Health and Social Care includes life sciences, research, health protection, rare diseases, data and technology. Lord Bethell, thank you so much for making the time in your busy schedule to tell us about the next phase of the implementation of the National Genomic Healthcare Strategy. I'm sure I speak for the whole of the genomics community in saying we are keen to learn more. I will now pass over to Lord Bethell.
Mark, thank you very much indeed for that very, very kind introduction. And I have got a humdinger for you with 5 big points I want to try and make. So hopefully I won't disappoint. Mark, as I've said previously, and I won't go over it again, I am personally completely fascinated by my own genes. And I am also hugely ambitious for the potential of genomics. So I'm really delighted to be here at the launch of our first Genome UK implementation plan. The publication of our new National Genomic Healthcare Strategy last September was done in the middle of the pandemic, and it required a huge effort. It would have been under tight timing restrictions in any case, but doing it under those circumstances was really tough. And I am massively grateful to everyone concerned who contributed to that. And in retrospect, it does mean that because we went the extra mile then, we are now in a great shape to be talking about implementation today. So thank you very much indeed. Now, we all know that genomics is changing the future of health and medicine. Genome UK set out our 10-year vision to create the most advanced genomic healthcare system in the world, delivering better healthcare at a lower cost. And we are making fantastic progress on that. From improved diagnosis of both common and rare disease to more targeted treatments for cancer, genomics also has the incredible potential to prevent disease before it even appears. Genomics also plays a crucial part in our economic recovery. It creates high quality jobs for the future right here in the UK, helping us to build back better. In 2018-19, the genomics industry contributed 1.9 billion to our economy. Not only does genomics create jobs, it also has enormous potential to improve the efficiency and cost effectiveness of running the NHS in an aging society. So thanks to the achievements made over the last 70 years, from the discovery of the structure of DNA to the completion of the 100,000 Genomes Project, the UK is rightly recognised as a world leader in genomics. We have continued to build on these successes, and it's now time to turn our vision into a reality once more. My team have been working hard behind the scenes, bringing together leaders across the genomics community to develop a plan to make Genome UK a reality. For the UK to remain at the forefront of international competition in genomic research and healthcare, to attract attention, to attract investment, we need to start delivering on key commitments set out in that strategy. And that's why I'm absolutely thrilled to be here to discuss the first implementation plan for Genome UK. And as part of this, I want to announce a series of headline initiatives, 5 in total. It's really impressive. Firstly, Genomics England will address the historic underrepresentation of ethnic minority groups in genomic programs. This one I am particularly pleased about because we have had so much emphasis on this issue during the pandemic. It's absolutely crucial to ensure inclusion and diversity in genomic healthcare. This is not just about ensuring equitable access, it is about ensuring representative diversity in our genomic datasets. This will enable everyone to benefit from the enormous potential of new techniques based on advanced analytics, such as polygenic risk scores and pharmacogenomics. With this commitment, we will be directly addressing health inequalities through engaging closely with communities and bespoke screening programs. Secondly, I'm excited to announce that whole genome sequencing is now up and running in the NHS Genomic Medicine Service for patients with a suspected rare disease and certain cancers. The NHS has already done a tremendous job in implementing a range of new genomic services and tests for patients across England through the NHS Genomic Medicine Service. But the 100,000 Genome Project proved the unparalleled value of whole genome sequencing in a clinical setting. 1 in 4 participants with a rare disease who joined the 100,000 Genomes Project without a diagnosis has now received one. That's a really powerful statistic. I am delighted that the benefits of whole genome sequencing are now available to patients as part of routine care. This makes the NHS the only integrated healthcare system in the world routinely offering this exciting test. This is a truly transformational milestone for patients. It brings us one step closer to achieving our ambition of sequencing 500,000 whole genomes through the NHS Genomic Medicine Service by 2023-24. And by the end of 2021, all 500,000 participants in UK Biobank will have had their whole genome sequenced. Together, these commitments lead us towards our ambition to sequence 1 million whole genomes. Thirdly, Genomics England, in partnership with the NHS, will lead proof of concept work on next generation approaches from diagnosis and treatment of cancer using genomics. Now, I spoke to Chris Wigley recently when appearing on his hit Life Sciences podcast sensation, The G Word. He asks, by the way, that everyone should give it a 5-star rating on the Apple Store if they haven't done already. We reflected on the fact that technology has developed enormously since we originally launched the 100,000 Genomes Project. We've seen great leaps forward in genomic sequencing and in data processing, particularly the integration of multiple data sources. This initiative will explore how we can utilize these scientific advances in the NHS to lay foundations for faster, more comprehensive genomic testing for cancer. Now, we all know the benefits of patient survival rates if cancers could routinely be detected at an earlier stage. But let me give you just one illustrative and very powerful example. Bowel cancer. 92% of patients diagnosed at stage 1 survived the disease for at least 5 years, compared to 10% diagnosed at stage 4. That is a very vivid illustration of the value that genomics brings to diagnostics. Fourthly, our 4th headline announcement is that our Future Health, the UK's largest ever research programme, will start recruiting participants this year. This is an important step towards their target of recruiting 5 million diverse volunteers. Our Future Health will collect and link multiple sources of information which are relevant to health, including genomic data. This will help researchers to discover new ways to detect and prevent the development of diseases, and it will provide an unprecedented resource to drive developments of diagnostics, including the evaluation of polygenic risk scores at scale. You may be aware of our Future Health through its previous name, the Accelerating Detection of Diseases Challenge. It was established through a £79 million of UKRI funding, and it will be an invaluable part of the ecosystem for years to come. Fifthly, and lastly, but by no means least, is that over the next 5 years, we will be providing funding to the Global Alliance for Genomics and Health. This will boost the development of standards and policies for sharing genomic and related health data. The Alliance brings together the best minds to establish frameworks and standards for voluntary and secure sharing of data internationally. Our ambition is to create a health and care system that can harness the power of data to improve outcomes for patients. We can achieve this by analysing genomic data alongside other population-level health information to find links between genomes and disease. But we can only achieve this with patient trust and consent. This commitment would not be possible without funding from the National Institute for Health Research, the Medical Research Council, and the Wellcome Trust. So what I've just outlined are only a few of the exciting developments included in the implementation plan. The full publication sets out a total of 27 pioneering actions, which are being carried out this year to deliver on the ambitions in Genome UK. It is well worth a read. But I also want to emphasise that genomics is just one example of the government's commitment to driving forward health innovation in the UK. Beyond genomics, delivering better innovation in healthcare will depend on strong data and analytics, as well as other cutting-edge technologies and treatments such as artificial intelligence. Healthcare innovations are key to rebalancing our healthcare system, to shift our focus from acute intervention to early stage prevention. This is absolutely vital to relieve demands on frontline services, secure a sustainable future for our NHS, and to empower patients to take greater control over their health. We must seize the opportunity to put the UK at the forefront of this healthcare revolution, with support for health innovation, including genomics, at the centre of all of our efforts. This will be central to our future health resilience, the growth of our world-leading life sciences sector, and improving patient care. We cannot achieve the best genomic healthcare system in the world overnight. Genome UK therefore covers a 10-year period, so we think it is right that the implementation should also be phased. Genomics is a fast-moving field. A phased approach will allow us to review our commitments and incorporate emerging science and latest research findings. So this implementation plan is therefore the first of many, with future updates bringing it closer to our goal. Please watch this space. Mark, thank you very much indeed.
Lord Bethell, thank you so much for the details of the ambitious plan for the next year. You have given us a great deal to consider, and clearly there's a lot to do. We appreciate that your schedule sadly does not allow you to stay on and discuss the plan further. So thank you very much for your time and leadership in continuing to support and drive the development of genomics and healthcare in the UK. Thank you. So I'm really pleased to be joined today by 4 leading national figures in genomics whose expertise and efforts will be absolutely crucial in taking forward the plans that Lord Bethell has just outlined. They are John Stewart, Director of Specialised Commissioning, NHS England, Chris Wigley, Chief Executive, Genomics England, Professor Annika Lucassen, Professor of Clinical Genetics at the University of Southampton, and Professor Sahir Garbia, Chief Scientific Lead for Genomics at the National Infection Service, Public Health England. Welcome, and thank you very much for joining us today to discuss the implementation plan. So if I could go to you first, John, with the rollout of whole genome sequencing for rare diseases and certain cancers in the Genomic Medicine Service, what do you believe are the opportunities and challenges for NHS England in the coming year?
Thank you very much, Mark, and it's great to be here today at this event. So perhaps I could actually just begin by thanking everyone working in the NHS Genomic Medicine Service for all they have done over the last year during the pandemic. I think it's important to recognise that keeping urgent genomic testing going whilst working hard behind the scenes on the implementation of whole genome sequencing, as well as the rollout of other new services like NTRAC and DPYD testing, has really been an incredible effort. But there are probably, 4, perhaps 5 things that I'd particularly highlight. So the pandemic has clearly revealed how strong a position the UK has already established globally in terms of genomics, with around half of sequencing in the world performed in the UK. So firstly, I think the strong clinical, scientific, laboratory infrastructure we have in place undoubtedly provides a really great springboard for further advancing the use of genomic medicine as part of routine clinical care in the coming years. Secondly, our new Genomic Medicine Service Alliances, launched back in December last year, I think provide a real opportunity to embed genomics now equitably across the NHS in England and address the local and regional variation, working in particular with organisations such as the Emerging Integrated Care Systems, Cancer Alliances, and others to improve patient pathways and drive change locally. The third thing I'd probably draw out is the focus on partnerships that have been established. The successful 100,000 Genomes project was incredibly important in terms of building strong and lasting collaborations with Genomics England, Health Education England, academia, patients and industry. And these collaborations will need to be maintained and wherever possible strengthened as we all continue to work towards a set of shared goals. Fourthly, I think is almost the universal support across the system for the changes we want to deliver, and the huge potential across many clinical areas for genomics to make a difference. And I think that's not just in clinical areas like cancer and rare diseases, but also through the work our alliances are leading on cardiovascular disease, diabetes, pathology, nursing and midwifery to deliver a real transformation across the NHS. And then perhaps, just finally, I think, and probably most importantly, is just the huge opportunities that genomics has to benefit patients, including providing earlier and faster diagnosis for patients with rare or previously undiagnosed conditions, opening up access, I think, to treatments and interventions, including novel therapies based on genomic results, helping people to predict a patient's response and prevent adverse reactions to treatment. So, look, I think, a huge hugely strong platform on which to build and take forward our plans in the months and years ahead.
Thank you, John. If I could come to you, Chris, I mean, clearly Lord Bethell has outlined some of the sort of very important initiatives that Genomics England is taking forward. So how do you see the next year from the perspective of Genomics England? What will be the sort of main priorities, but also where do you see the challenges?
Well, I think our first priority is to get Lord Bethell formally signed up as our PR agent for the podcast. That was great. I mean, I would divide this into a couple of sections. One is what has, for the last year or so, started to become our kind of core business. John mentioned the 100,000 Genomes project. That project at the level of sequencing and interpretation of the primary findings is largely complete. We still need to keep working with the participants there. We need to keep reanalyzing that data. There is more to do. But with Genomics England moving into this new phase, we're really anchored around two big services. So the first service is the whole genome sequence diagnostics in the NHS. So really closely working with John, with Sue Hill and team around that. And our role in that is to take the raw data off the sequencing machines, do the interpretation, keep innovating about how many insights we can squeeze from each genome, and feeding those back into the NHS system, really with the goal of creating, it all being about human stories and creating more happy endings for as many of those human stories as we can. All of that data then creates an extraordinary asset for research. So over the last year, we have unsurprisingly had a huge focus on COVID, working closely with the recovery trials, with Genomic, with React, with ISWIC4C, that whole ecosystem around what we can learn from the genomics of humans, of the virus, to help with the response to that. But of course, we have a much wider research agenda across all sorts of different disease areas like neurodegenerative, musculoskeletal, and so on, where we have over 3,000 researchers registered in the environment and 130 private companies that we're working with. And a big part of our focus there is really scaling those operations, but making sure that we're feeding back the insights from research into the delivery of healthcare, whether that's at an individual level or whether that's at the level of a new insight about a way of doing things. And so scaling those two services, the sort of healthcare partnership with the NHS and the research partnership with various academic and biotech researchers is kind of the core. Lord Bethell flagged 3 of the initiatives that we're scaling up this year as well. Firstly, around diversity. If COVID showed us many things, one of which was the awful extreme of the differential effects on different ethnic groups and different and communities who are suffering different levels of deprivation. And both of those angles are really important for us as we're looking to make sure that as we move into an era of personalized medicine, those insights are available to everyone. Even it was just this weekend, there's now criticism that a new app for melanoma identification using a smartphone doesn't work on people with darker skin. We would like to think that these kinds of issues are becoming historic, but we have to keep working every day to make sure that that is true, because if we don't have the data sets, we can't create that equity of access. So that's a big push. The second one is on cancer. So our role here is really around landscape scanning. There is so much amazing technology and science emerging every day. How do we consolidate that and make it relevant to patients, again, in close partnership with the NHS? And the final one on newborn sequencing. So the focus this year is really on building on a lot of fantastic ethics and engagement work that has gone on around identifying what the opportunity is for newborns. There is currently the heel prick test that a new baby gets, which identifies 9 potential things that a baby might or might not have. At its most simple, newborn sequencing would say, actually, we can, in addition to those 9, we can actually test for 200 or 300 other conditions that a baby might have, where if we have this change in the genome, we are very confident that we will have this issue in the human, and we know that there is something we can do about them, and we know that the earlier we intervene, the better the outcomes are for the person. So that's really what we're working up. We're really excited that Sarah Jane Marsh is going to be our NHS champion for this at Birmingham Women's and Children's, who's fantastic, and we'll be working with her and the team really closely, both on thinking about what that could look like as a clinical service, as well as doing lots of engagement with kind of midwives, with nurses, with expectant parents and newborn parents, and so on. So yeah, those 5 areas are keeping us pretty busy, all of which is underpinned by our ongoing work around engagement and trying to build a sort of national conversation around genomics, which things like the podcast, the G Word, are part of. We're hiring, so if anyone listening is interested in coming and working for Genomics England, please let us know. All of our jobs are on the website. We're scaling quite a lot this year, and contributing to a refresh of the government's life sciences vision, which will be happening over the next few months, and will then feed into the spending review. So never a dull moment.
Thank you, Chris. Yes, absolutely. Very interesting, full program of activities, and we may come back to certain points of those, but I just wanted to move to Annika. We've heard from Lord Bethell, also from John and from Chris, and I just wanted to sort of ask you what your perspective is, and what do you think the plans mean for the clinical genomics community?
Thank you. Many thanks for inviting me to this. I think for the clinical genomics community, these developments are undoubtedly a good thing. That goes without saying, really. And I've been in the field for quite a long time now, so I've really seen the diagnostic power that I might have in the clinic shift from one that's limited by the technology to one that's much further downstream. So the technology is now there. The question is now about interpreting it quickly enough and accurately enough for the patient in front of you. And into that, of course, come all the things that we've heard about issues about genetic ancestry and ethnic factors. In fact, we know much more about genetic variation in people of Northern European ancestry than anyone else, so we really need to work on that. So I'm very encouraged to hear about those plans. I think of this a little bit like other types of technology coming in. So, for example, getting a whole body MRI scan 10 years ago would have been almost impossible, whereas now it's relatively straightforward, but you still need to be able to interpret that scan. And I think it's still all too common for people to imagine that now we have the technology, results will leap out from that, and that we don't need clinical interpretation skills to be able to say what the findings mean for a patient in front of you. So I think that's something that we really need to work on. We really need to develop the multidisciplinary skills that the clinical community has, but at the moment I think are all too focused on a very small group of that community. So we really need to widen that multi-disciplinary approach. And we also need to, if we're thinking about the analogy with MRI scans, we also need to think about those key differences with an MRI scan. For example, that a genomic code will tell you something about what might happen in the future, as well as what is the problem now. What is the diagnosis now is almost easier than what might happen in the future, and also what might my relatives be at risk of. So there are two extra features that I think we really need to focus on now that the technology has shifted. We can rapidly provide insights into people's genetic code. We now really need to focus on the subtleties of interpretation of that.
Thank you, Annika. I was just wondering, did John or Chris have any further comments to the points raised by Annika? John?
Yeah, just while we're talking about what these plans mean for the clinical community, I think it's worth just flagging that we're going to be going out to public consultation on our clinical genomics service specification, which is widely supported by the clinical and scientific community and wider stakeholders. This is going to include new quality indicators, more emphasis on inherited cancers. It's also hopefully going to better reflect new ways of working, such as remote consultations and the split between clinical and laboratory services. So I just wanted to kind of flag that that's going to be something that we're going to be consulting on really quite soon, definitely I think before the summer. So important thing to say, watch out.
Absolutely. Thank you, John. Chris?
Only, I think, to echo the central role of the clinical genomics community, and it's both in terms of actually doing that science, but also having the really human conversations and sort of support of individuals and families who are either dealing with cancer or dealing with rare disease or dealing with other issues in their lives. And I think that one of the pieces we've tried to draw out through the Genome UK strategy is, as this comes into the mainstream, as it becomes like an MRI scan or even ultimately like an X-ray or something, how do we scale that support mechanism so that we're not believing that technology can solve all of these problems? I think they have to remain really, really human situations. And the work that Annika and many others are doing in this space, I think is going to be absolutely vital.
Thank you, Chris. If I could come to Sahir, please. I mean, clearly there has been an exceptional progress in the area of pathogen genomics during the pandemic, but what will the public health system be progressing as part of the implementation plan?
Thank you, Mark. It's almost like trying to build a new plane while you're still flying. As we continue to respond to the changes that are happening in the virus and how it's transmitted, not just in the UK, but the difficulty is you need to interpret it because it's changing across the entire global landscape. And changes in one country will have major impact and direct influence on what happens in another, whether it's in vaccine, in travel, severity of disease transmission, and how we interpret it. So pathogen genomics and specifically COVID directed genome sequencing have been one of the areas that grow organically. I think in public health system, we have been for years trying to ensure that we have that global network and being able to ensure we have enough surveillance and intelligence on how pathogens change and what do these mutations mean. In this pandemic, we have to learn that on a weekly basis, and we have to respond to it on a daily basis. And that complexity itself has propelled, as Chris said, is the need to respond to what innovations need to come in place. How do you integrate the knowledge from human genomics and pathogen genomics, not just in looking at the technology and how we answer the question, but also how people are going to respond to these and what the new design should look like. So looking towards the changes that are happening in the public health system, global interaction, diversity of pathogens in the UK, and the fact that we do have communities that have been, in a way, not represented in our data and data structure, both because of social framework, because of location, and because of other compounding factor, whether it's genetics, economical, or due to a whole range of logistics. I think we now recognize that that set of information need to be integrated together for any public health system to be able to deliver, and deliver wider than just responding to an outbreak or a pandemic. It's to bring security to a system that can function and operate seamlessly moving forward. So I think any public health system utilizing genomics, if it's not integrated into a wider strategy, into that framework across, would be limited in its ability to respond. And I think that's what we look forward to.
Thank you, Sahir. And just to sort of explore that a bit further, because I was thinking whilst you were, presenting those perspectives and priorities for the future, what opportunity is there for embedding pathogen genomics into routine NHS and public health practice?
That's quite an interesting question, because Mark, we've started embedding pathogen genomics since 2010. I think the challenge has continued to be is the fact that pathogen genomics need to happen at a pace and fast for it to be of effect to NHS response to patient and patient infection. And a response that take 5 to 6 days, by then you've either treated the patient or they recovered and they moved. How do we ensure that we balance that our surveillance system does not preclude the ability to diagnose and bring to the front? Looking at where we are now, these challenges there, but the technologies have moved enough that we've got predictive frameworks. So for example, being able to ensure we have a full surveillance and antimicrobial resistance mechanisms, wherever they are within the system in related to pathogens, would start to drive a rapid genomic response and a rapid screening selection of which antibiotics should be used in which communities and in which location. I think we have an opportunity for integrating pathogen genomic not as a just tool for surveillance, but a predictive tool for response. And I think if we can bring those together successfully, it becomes an effective mechanism and becomes a seamless process. But also very key is to ensure that that information is available for the research community, and that information is global. That global interaction is vital for sharing this key information.
Thank you, Sahir. And am I correct in saying that you're also working very closely with NHS England in order to move this agenda to implementation? Is that correct?
Completely. If we can build within the next 4 to 5 years a system of pathogen genomics that's embedded as close to patient as we need it, and close to community as well, not just in hospital, but actually within the community, and that data is seamlessly linked together and build on the knowledge that Chris and John and colleague have discussed in Genomics England, and build on its own framework for that across the country. I think we would be bringing genomic to a utility tool for health in the country.
Thank you, Sahir. That's fascinating. I just wanted to ask the other panel members if they had any comments with regards to pathogen genomics. No, I think they're stunned by the possibilities. Thank you.
I think I would only make the point that this time last year, we were talking about one of the goals of the response being not just to deal with the response, but also to lay track and build infrastructure so that we could respond better in future. And I think thanks to Sahir and thousands literally of other people, we have done that, which is extraordinary, not just for future pandemics, but also for, as Sahir says, like the rolling of that into actually routine care. I think we've had a decade of progress in a year, as in some other areas.
And the thing I'd like to reflect is that once upon a time, genetics and infections were seen as completely opposite poles of a spectrum that never the twain should meet. And this demonstrates beautifully how they are very interrelated.
Excellent. Thank you. I was just going to move back to John. Obviously, an exciting agenda at the moment, across different disciplines and different sectors. So what steps will NHS England be taking to ensure that NHS adopts new and appropriate genomic technologies more quickly?
Yeah, a great question, Mark. So look, first off, I think it's probably important to stress that we are already introducing genomic technologies faster than most other countries in the world. And we are, of course, on track to be the first publicly funded health system to offer whole genome sequencing as part of routine care. So I think, starting point to acknowledge. But in addition, despite the pandemic, over the past 18 months, we've introduced a number of other new advancements, and these have included histology-independent treatments for cancer. So here, within weeks of them being licensed, genomic testing for NTRK gene fusions was implemented across the NHS Genomic Medicine Service. And that's really got the potential for 30,000 patients a year to benefit. Similarly, we've put in place a rapid exome sequencing service for neonatal intensive care patients and pediatric intensive care patients. Around 1,000 children have benefited from this testing, with around 37% getting a diagnosis. And that is more than double what we would have achieved with standard of care testing. Thirdly, probably worth mentioning DPYD testing. And here, testing has been implemented to look at variants in the DPYD gene, which may increase the risk of adverse drug reactions to commonly used cancer chemotherapy. So up to 38,000 cancer patients could benefit from this testing per year. And perhaps, finally, I'd just maybe flag the large-scale pilot with GRAIL, which is underway, which is really paving the way in cancer for a world-leading programme that will be piloted with 165,000 patients and a worldwide first deal struck by NHS England. So I think some really exciting developments by bringing together our genomics team alongside specialised services, our conversations with NICE, our commercial capability, to really make some rapid progress. Perhaps I could just conclude by just emphasising actually that there are huge learnings from increasingly working more closely with the Accelerated Access Collaborative, the MHRA, with NICE, industry and others on the introduction of new treatments more broadly across specialised services, which I'm responsible for. We've now got comprehensive infrastructure in place for horizon scanning and evaluating proposed updates for genomic testing, which is outlined in the National Genomic Test Directory, and that is regularly kept updated and is managed by our Genomics Clinical Reference Group and a number of expert test evaluation working groups. Finally, maybe I'd say, as the implementation plan sets out, we've also launched an NHS Genomic Medicine Service research collaborative in partnership with Genomics England and the NIHR, and that is to support promising new genomic research by facilitating access to the NHS GMS. So I think lots of progress over the last 18 months, even despite the challenges of the pandemic.
Absolutely. Thank you, John. I just wanted to come back to you, Annika, in terms of, your particular clinical discipline has experienced this sort of dramatic change and the power of diagnostics and the new technologies. I would say that you were one of the disciplines who have represented this fast pace of implementation in terms of technology. What are your thoughts in terms of what the impacts will be and what the needs are of the clinicians and patients and their carers in terms of adoption of new technologies, such as outlined by John?
Sorry, other specialties, you mean?
No, I was just making a general comment about, your specialty has actually experienced it. What learning did you get from that in terms of what we need to do more broadly?
I think that's a really good question. I suppose what we need to do more broadly is acknowledge that a lot of what comes out of a genome is clear-cut and will give us a diagnosis or accelerate, improve the diagnostic quality for many, many patients. But what we now need to do is realise that some of the findings that come out of a genome are subtle, don't in themselves tell you what's going to happen or what is a diagnosis, but are in combination with other factors, pathogens, for example, or a load of other factors throughout the genome. And in order to find that out more clearly than our patients expect at the moment, and think we need to study very large data sets, and that often then ends up in a sort of research realm. And we need to acknowledge that a finding now may evolve over time. So we may, as we get more information from large data sets, get more evidence. And as we get more evidence, our finding may change. And I suppose, again, I would say that the expectation of a genome is often of a blueprint. It's in our DNA. I'm fascinated by my genes, as Lord Bethell said, as being something clear-cut. And we really need to get the message out there that whilst we've got this fantastic improvement in diagnosis, there's still an awful lot of uncertainty, bits of interpretation left to do, and interpretation that will change over time. And I think that message needs to be out there more clearly so that we can meet the expectations of the people who come to us.
Thank you, Annika. That's really helpful. I just wanted to come back to Sahir. Sahir, do you have similar issues in pathogen genomics, or I hasten to say, is it easier? I don't know. That's probably wrong.
Well, I think the challenge is mutations are happening all the time. And when you think about microbial genomes, pathogen genomes, they are a lot smaller. So the impact of the rate of change is a lot higher. And how do you continue to decipher between what is the impact of these changes? I mean, for example, at the moment, when we talk about variants of concerns, for example, the assumption is that there is certain specific mutation, and that is the only mutation that is happening in that strain as it is spreading. And the reality is every time it's replicating, we're getting additional mutations. Some of them will be successful and maintained, and some will disappear. Some will have a direct impact, and some will not influence where the process are complicated. And I think what is important is that data analytic and almost data intelligence. I think we need to move from collecting information and try to decipher what that is to a position where we start to recognize what is the impact of this pattern of changes and how do we predict them, and what level of response we need to put into our judgment, from observational to almost being judgmental. And I think that's a factor that I don't think we have the knowledge or the courage at the moment, but having programs such as UK Genomics and our strategy over the next 5 years will start to contribute that into the system.
Thank you very much, Sahir. Coming back to you, Chris, I mean, different topic. What are the plans for the new next generation trusted research environment?
Yeah, hot topic. It's interesting. So just for those who aren't immersed in this world, so what do we mean by a trusted research environment? In the old world, so to speak, when we were doing research or putting data sets together for the purpose of sharing with a research community, you would just share that data with them. You'd put it on a hard drive, put it in the post, allow them to download it, whatever. At Genomics England, we now have about 50 petabytes of data, which, to put it in context, is about the same as Netflix, apparently. So a lot of data, in short, and it just doesn't work to download that. For example, at one point, we were talking about moving from one provider of server farm services to another. I said, well, look, surely we can just run a high-speed link between it and transfer the data. I said, yeah, we can do that, and it'll take 9 months. I was like, wow, okay. So point one is lots of data. Point two is we need to be really, really thoughtful about what we're doing with the incredibly sensitive data sets that we hold. So if they're de-identified, but you can kind of think of it like a piece of paper that has your fingerprints on it. If you rip off the bit at the bit at the top that has your name on it, it's still your fingerprints, right? So there's an inherent identifiability challenge here. So what a trusted research environment does is provide a research environment, as the name suggests, which researchers can come to and do their work in that environment. Genomics England actually built one of the first of these in the world over the course of a few years from kind of 2013-14 onwards. And to some extent, by the time I arrived at Genomics England in late 2019, we were sort of suffering from first mover disadvantage in that a lot of large organizations around the world, like the Googles, the Microsofts, others had invested a lot of time in solving some of the problems that we had been solving ourselves. And so what we did, and you know, there are all sorts of benefits of us replatforming that. It enables all sorts of new workflows, like collaborative workflows, like working on federated data sets where we don't have to merge the data sets, which has all sorts of legal and privacy issues. We can do the analysis on disparate data sets and so on. And so we stood up at high speed during the first wave of the crisis, a new cloud-based platform for our COVID research. And what we're now doing is effectively building on that foundation to build a more sort of stable and scalable cloud environment. So we're partnered with a British startup called LifeBit and sitting on top of Amazon Web Services, so it can effectively scale to infinity. We've worked with a bunch of our biotech and pharma partners to stand them up in that environment, which is going really well. There's a much better researcher experience. And we're figuring out how we gradually migrate our academic partners from one to the other. We want to make sure that we're not disrupting research. And so there'll be a period where we sort of dual run. Yeah, it's a very promising environment. And UK Biobank, as they move into the world of whole genomes, are exploring similar pieces. So we're working really closely with them to sort of share learnings and explore how we can do things like federate across the Biobank and Genomics England data sets. And as our future health stands up, we're collaborating with them as well around making sure that we're not sort of duplicating or triplicating infrastructure. So an exciting area with lots of rapid movement. But I think if our aspiration is to build the smartest healthcare system in the world, then having the ability to feed these kinds of research insights back into the system through things like the NHS Digital Spine and so on, joining these bits up is going to be incredibly powerful.
Absolutely, Chris. Annika, did you want to comment?
Well, just to really emphasize what Chris is saying, how important it is, and how important it is in genomics in particular, because the boundary between what is research and what is clinical practice is far from clear often. And yet we know that we've got very different governance systems for both. So when you're talking about de-identifying, that's different in a research setting than it is in the clinical setting. And there's an awful lot of learning from genomic data that happens in a sort of hinterland between the two, where we've got no governance system. And we really need, I think, as a community to inhabit that hinterland a bit better. I don't quite know how that happens, but we need to open a conversation about that and think about ways of governing that hinterland, because otherwise we're going to get really stuck with always putting up a wall between, is this research or is this clinical practice? What sort of consent do we take? What are we allowed to share? And we'll stop learning from the data in a way that we can then use in healthcare.
Thank you, Annika. Chris, did you want to come back in?
No, only to say, yeah, spot on. I mean, I think, and Annika's points get brought to life for us on a day-to-day basis, just by the reality of the world, right? I mean, we're partnered with a few groups of research academics who work in NHS hospitals who are looking at particular types of cancers. So for example, there's one called SMP, it's looking at pediatric cancers, like kids with cancer. They're working on an identified group of patients. They're sequencing their whole genomes in partnership with Sue's team and us. They're then trying to make the best possible clinical decision for that child, which might well include, for example, a referral to a clinical trial. There's a group of children, it's not just one child. Is that research? Is it clinical? Should they be looking at that on an identified basis, on a de-identified basis? Should they join one of the research communities within Genomics England? generate the insights, and then we can then re-identify that for them. Is that ridiculously cumbersome? You know, we're trying to sort of work through some of these real life examples in order to, I guess, put some meat on the otherwise theoretical bones. Like, these things have to work day to day in the real world for real people doing real stuff for the benefit of real patients.
Thank you, Chris. And Annika, the implementation plan gives a commitment to provide funding to the Global Alliance for Genomics and Health to develop standards for sharing genomic and related health data. What impact could this have on clinicians working in the NHS?
Yeah, I mean, I think that follows on really nicely from my previous point that we've got to, in order to be able to interpret genomes effectively for patients in the clinic, we need very, very large collections of data that link genotype with phenotype, i.e. clinical features, family histories, other things other than genetics. And I think GA4GH is a global community that starts to collect those on a scale that we can do something with. I think membership around the world hopefully will increase. The UK is pretty good at membership. I gather there's 87 organisations in the UK that are a member, and Decipher was one of the very early adopters, BSGM also. I think that's only a good thing. It's a way of collecting very large data sets with clinical features, phenotype, that help us to interpret. We still need to answer that question of, is that research or is that something slightly different? And if it is something slightly different, if we have got this sort of hybrid terrain now in terms of both interpreting data from others for the patient in front of us and our patient contributing to research for the future, how can we make sure that we practice ethically in that terrain? I think that will be really important.
Thank you, Annika. And from a practical question, how do the standards developed actually get implemented in the UK? Is that a seamless process?
Well, I'd like to think it was, but I mean, on a sort of high level, I think it's learning from data that comes back then into practice with evidence. I'm sure that others can speak much better to the sort of regulatory hurdles that are in place from a global perspective to a UK perspective. Yeah, I'm not quite sure if that's what you're asking, Mark. But
many and various regulatory hurdles, definitely.
Yeah. But the principle of learning from data, from large-scale data sets, so that we can be more robust in our interpretation for the individual, I think is very much a good thing.
And also the global endeavor, which is essential and central to the genomics understanding.
Global to include populations other than those of Northern European ancestry, which I think is really crucial.
Yeah. Thank you, Annika. I'm afraid I'm just checking the time. I'm sorry to say that we've run out of time. So I'm really sorry about this, as we've only scratched the surface of what we could talk about. But I'm afraid I'm going to have to draw our discussions to a close. However, I'm sure that the wider conversation is only beginning, and we will be interested to hear the reactions to these plans from the UK genomics community over the coming days and weeks. It only remains for me to thank all our expert panelists, Annika, Sahir, Chris and John, for sharing their priorities and perspectives. Finally, thank you all for joining us today. We hope you have found it interesting, and goodbye.
Thank you. Goodbye.